For decades, treating migraine always felt like, well, a trade-off. You'd get efficacy, but it often came with risks. And prevention? That was a completely separate battle from getting acute relief. But what if we could change that? Today, we're going to explore the Gepants, a class of drugs and one in particular that is totally rewriting the rules for how we manage migraine. Just imagine your next migraine patient. What if you could give them a single medication that not only stops an attack right in its tracks, but if you use it a different way, can also prevent future attacks from even starting? This idea, this dual action agent, it's not just about convenience. It's a fundamental shift in how we approach the entire spectrum of this really debilitating neurological condition. All right, so here's our game plan. First, we'll set the stage by looking at the clinical problem, the unmet needs in traditional migraine care. Then we're going to dive into the pathophysiology, the CGRP pathway, which really unlocked this new therapeutic target. Once we have that foundation, we'll zero in on Rimegepant itself, its mechanism, the clinical data that backs it up, and, most importantly, where it fits into our modern therapy toolbox. Okay, let's kick things off with Section 1, Migraine's Unmet Needs. To really appreciate why a drug like Rimegepant is such a big deal, you first have to understand the cracks in the foundation of our traditional treatments, what you could call the old guard. For years and years, our main defense has been the triptans. And they're effective, sure, but their vasoconstrictive action is a complete non-starter for any patient with cardiovascular risks. And that's a huge portion of the population. For other folks, we lean on NSAIDs, but that brings the very real risk of medication overuse headache, MOH, which just traps patients in this vicious cycle of pain. The bottom line is, for a huge group of migraine sufferers, our best tools were either too risky or they just didn't work well enough. That left a major therapeutic gap. So that gap really pushed researchers to dig deeper into what's actually going on during a migraine. And that brings us to Section 2, targeting CGRP. This is the science that literally paved the way for this breakthrough. The crucial discovery here was identifying something called calcitonin gene-related peptide, or CGRP. We now know that this little neuropeptide is basically one of the main villains in the migraine story. During an attack, CGRP levels just spike. Its release triggers vasodilation and kicks off the transmission of pain signals all through the trigeminal system. This was a game changer because it gave us a brand new target. The theory was if we can block CGRP, we could stop the migraine cascade right at its source. And this visualizes that exact moment of action. You see the trigeminal nerve releasing CGRP, which acts like a key looking for its lock, the CGRP receptor on blood vessels and nerve fibers. Once it binds, boom, the pain cascade starts. Now, Gepants, like Rimegepant, work as antagonists. They basically get to the lock first and block it, so the CGRP key can't get in. It's a pretty simple, elegant mechanism. No binding means no downstream signaling, and no pain. So, to put it simply, the cascade is activation leads to release, which leads to binding, which ultimately causes pain. The entire strategy of the Gepant class is to just interrupt that chain reaction right there at the binding step. And that brings us to our focus agent. So here we are, Section 3, and our focus agent, Rimegepant. As a second-generation Gepant, it was specifically engineered to block that CGRP pathway both safely and effectively. Let's break down the key features that really define Rimegepant. It's a small molecule CGRP receptor antagonist. Now, the fact that it's second generation is so important. The first-gen agents actually failed due to liver toxicity concerns. The formulation is an ODT, an orally disintegrating tablet. That means it absorbs quickly without needing water, which is a massive plus for a patient who's feeling nauseous. But the truly revolutionary part, it's dual indication. It is the first drug ever approved for both acute relief and the prevention of episodic migraine. That one feature completely changes its place in therapy. Now for a key pharmacokinetic value you'll want to remember, an elimination half-life of about 11 hours. This is a huge contrast to the CGRP monoclonal antibodies, where we measure half-lives in weeks. This much shorter duration gives us way more clinical flexibility, and we'll circle back to why that matters in a bit. When you're treating an acute attack, onset is everything. Rimegepant hits its max plasma concentration, or Tmax, in about 1.5 hours. This gives us and our patients a really clear expectation for when they should start feeling relief. And finally, from a practical drug-drug interaction standpoint, it is critical to know that it's primarily metabolized by CYP3A4. What that means for you is that you'll just need to be mindful when you're co-prescribing strong inhibitors or inducers of that enzyme. So, that's the theory. But does it actually hold up in practice? Well, that brings us to Section 4, the clinical evidence. Let's dig into the pivotal Phase 3 trial data that got Rimegepant its approvals. Okay, let's start with the acute treatment data. In this big trial, they looked at two key outcomes 2 hours after the dose. First, complete pain freedom. That's the gold standard. Second was freedom from the patient's self-identified most bothersome symptom, or MBS, which could be light sensitivity, sound sensitivity, or nausea. For pain freedom, almost 20% of patients on Rimegepant were pain-free, compared to 12% on placebo. For getting rid of that most bothersome symptom, the numbers were even better, nearly 38% versus 25%. Both of these results were highly statistically significant. The takeaway here is pretty clear. Now, it's not a silver bullet, but achieving complete pain freedom in nearly 1 out of every 5 patients at 2 hours, that's a clinically meaningful result, especially for those patients who can't take triptans or just don't respond to them. Now let's switch gears and look at its use as a preventive. In this trial, patients took a 75 milligram dose every other day. The main endpoint was the average reduction in monthly migraine days, or MMDs. The Rimegepant group saw 4.3 fewer migraine days per month compared to their baseline. The placebo group saw a 3.5-day reduction. And while that placebo effect is pretty common in migraine trials, the difference between the two was still statistically significant. So, what does this actually mean for a patient? It's tangible. The net benefit over placebo is nearly 1 full extra migraine-free day gained back every single month. For someone whose life is constantly disrupted by migraines, that 1 extra day of work, or family time, or just feeling well, that represents a major improvement in their quality of life. Okay, this brings us to our final and maybe most critical question in Section 5. With all this evidence, where does Rimegepant actually fit into our day-to-day clinical practice? Let's put it side by side with our other options to really understand its unique role in this new treatment landscape. All right, in the clinic, this is where the rubber meets the road. Compared to triptans, Rimegepant works differently, CGRP antagonism versus serotonin agonism. This means, and this is crucial, no vasoconstriction and no cardiovascular contraindication. Now, some studies suggest triptans might be, on the whole, a little more effective, but Rimegepant is generally better tolerated. So for your patient with cardiovascular risk factors where triptans are totally off limits, Rimegepant immediately jumps up as a first-line specific therapy for their acute attacks. And how does it stack up against the other CGRP therapies, the monoclonal antibodies? Well, the most obvious difference is how you take it, an oral tablet versus an injection. But the key pharmacological difference is that half-life. Rimegepant's 11 hours versus about 4 weeks for an antibody. That's a huge consideration for patients who might be planning a family, or if a side effect pops up and you need the drug cleared from their system quickly. And of course, Rimegepant's unique dual use for acute attacks is an advantage the antibodies just don't have. A recent review in the journals CNS Drugs really nails it, stating, as the first dual agent approved for both treatment and prevention of migraine, Rimegepant represents a useful option for the management of migraine in adults. You see, this isn't just another drug. It's a new category of treatment that really carves out its own very important niche. And that leaves us with one last big question. By breaking down that wall that has always separated acute and preventative therapy, are drugs like Rimegepant pushing us toward a much more integrated, more personalized future for migraine care? The answer really seems to be yes. The ability to use one medication flexibly to both treat an attack and lower the odds of the next one, that isn't just a new option. It's a whole new philosophy for managing this condition.